We will go to liver.
A section from the liver and the pancreas is illustrated with emphasis on the details of the liver lobule and duct system of the exocrine pancreas. Uh, on the left, they have highlighted the major organs: right lobe of liver, left lobe of liver, vena cava, gallbladder, common bile duct, pancreatic duct, and then hepatic artery and portal vein, sir. On the
Super.
image, they have shown liver. In that, they have labeled hepatocyte, central vein, hepatic sinusoids, bile canaliculi, portal triad, bile duct, hepatic portal vein, and hepatic artery, sir. And below in the pancreas, they have labeled pancreatic acini, intercalated ducts, uh, intralobular ducts, and below they have labeled centroacina cells, pancreatic acina cells, vein, capillary, beta cells, and alpha cells, sir.
Functional unit is the hexagonal plate. This is the one functional unit, and all the corners, it is known as portal triad because there are three structures: hepatic artery, portal vein, and bile duct. Okay, so those are all the three structures, and that's why it is called portal triad. And all the blood, normally, the portal vein, there are only two veins that carry good blood. One is portal vein, other one is the pulmonary vein. All these nutrients from the portal vein and oxygenated from blood from the hepatic artery, they go through from the periphery to the center, and then they form the venous system there, and that is the hepatic vein. So the hepatic vein is situated in the center portion of the functional unit of the liver. And the third structure, which is identified as green, is a bile duct. And the bile is produced by hepatocytes. That's very important to remember because we talk about hepatocytes and biliary epithelium. Logically, we think biliary epithelium will produce bile because it is biliary. That is wrong. Bile is produced by hepatocytes. The biliary epithelium produces mucin. So the bile comes into the bile duct, gets diluted by the mucin from the biliary epithelium and goes through the bile duct to gallbladder for storage. The biliary flow happens like this from the center to the periphery. Whereas hepatic artery and the bile duct, they go through the periphery to the center. Why it is very, very important? Even though it is divided into hexagonal functional plate, by nutrient wise, it has to be divided into three zones in the liver. Zone 1 is more like all the areas around the portal triad. Zone 2 is the middle zone. And zone 3 is the zone around the central veins. So that's why I put 1, 2, 3. Whenever there is an insult to the liver, which zone will be affected first, Hema, logically speaking? What is your understanding?
Sir, zone 3 will be affected, sir.
Super. Because it is having less nutrient and less oxygen, isn't it? And whenever there is an insult, zone 3 is the first area to be affected. Anatomically, there is no basement membrane like a plate. That also you have to understand. Because they talk about hepatic plate. It is there, but you don't see it histologically. There is no boundary like a basement membrane, like here, hexagonal basement membrane to differentiate. What cell usually will you see in acute inflammation?
Usually neutrophils, sir.
Super. In chronic inflammation?
Lymphocytes, sir.
Yeah. Before answering that, you should ask me what is the etiology? Why there is acute inflammation? If the acute inflammation is because of some organisms, like bacterial organisms, then acute is neutrophil and chronic is lymphocyte. When it is because of immunological response or immunological disease, in acute you get lymphocytes. This is very, very important to remember. And chronic you get fibrosis. Most of the hepatitis are immune based disease, even though they are classified hepatitis A, B, C, D, E, it is immune based. There is a lot of lymphoid infiltrate. When you see these lymphoid infiltrate confined to the portal triad, that is chronic hepatitis. When do you call acute hepatitis? When the lymphocytes spill over into the lobules from the portal triad. then you call it as acute hepatitis. So, in acute hepatitis, spillover, or the other terminology is interface hepatitis. It is present in between the junction of the portal triad and hepatocytes. Why I am paying attention? They may say the neutrophils coming out of the plate, portal triad plate, but there is no plate like that. The other terminology misnomer is piecemeal necrosis. There is no piece, there is no meal, there is no necrosis. So that's why it's totally misnomer, because you will read them in the textbooks. It is interface hepatitis. What do you understand by interface hepatitis?
So spillover of the inflammatory cells into the lobules, sir.
Super. And another very important thing you have to remember, see this the biliary duct. This biliary duct, they get the blood supply to them through the hepatic artery here. Why that is important? In transplant cases, when there is some disease in the hepatic artery, the first structure that will be affected will be the biliary tract. And whenever there is a biliary tract is obstructed, you get cholestasis.
Figure 14.1, pig liver lobules, panoramic view, transfer section, stain, Mallory as an low magnification. 1. Central vein, interlobular branches of bile duct, hepatic artery, portal vein, which is portal area. 5. Interlobular septum, plates of hepatic cells. Central vein, interlobular septum, hepatic sinusoids, interlobular branches of portal vein, bile duct, hepatic artery, portal area, hepatic lobule. Figure 14.2, primate liver lobule, panoramic view, transfer section, stain, hematoxylin, eosin, low magnification. Interlobular branches of bile duct, portal vein, hepatic artery, interlobular septum, hepatic sinusoid, central vein, plates of hepatic cells, central vein, interlobular septum, interlobular branches of portal vein, bile duct, hepatic arteries, portal area, hepatic lobule.
What do you think about hepatic artery and bile duct? Bile duct will be lined by cuboidal cells, whereas hepatic artery is lined by endothelial cells. But is there any similarity? Bile duct and hepatic artery are of same size. Whenever a bile duct is not there, you have to check whether it is really absent or it will come in the next levels. Or you can see more than one bile duct, because these bile ducts, they run like a serpentine pattern. So whenever they are cut like this, there will be multiple bile ducts. And whenever you see multiple bile ducts, you have to see whether they are all of same diameter with that of the hepatic artery. Because whenever there is a obstruction in the bile ducts will react by proliferating. And those bile duct proliferation are known as ductules, and they will be of smaller size. They won't be of the same size like hepatic artery. So when you see lot of bile ductules, what we call ductules, that means there is obstruction. What is the origin of biliary epithelium? From where they are arising? They are arising from the hepatocytes, and they are telling there may be some stem cells situated at the interface that gives rise to hepatocytes as well as biliary epithelium. Whenever there is a biliary ductular obstruction, there will be biliary duct obstruction, there will be biliary ductular proliferation, portal edema, and neutrophils in the portal triad. As I told you, when the lymphocytes are confined within the portal triad, that is, what do you call
Chronic, sir.
Chronic hepatitis. And when they are spillover in the lobules, so this is chronic hepatitis with activity. Because of the neutrophils in the portal triad, can you call it cholangitis? The neutrophil has to come and attack the biliary epithelium. Or what else will happen? Once they are in the epithelium, the inflammation is severe. What will happen next?
They move into the space, sir.
By seeing the neutrophils in the portal triad is not cholangitis. To call it as cholangitis, you have to see the inflammatory cells either attacking the biliary epithelium or inside the biliary lumen. Here I have drawn neutrophils. That means it may be some bacterial. And whenever there is immunological, rather than neutrophils, it will be lymphocytes. For example, there is a liver transplant, there is a rejection, and that rejection will attack the biliary epithelium. The lymphocyte should be attacking the biliary epithelium and they may be present within the lumen. But attacking the biliary epithelium is very, very important to call it as biliary inflammation.
14.3 bovine liver lobule, stain hematoxylin eosin, transverse section, that takes magnification. One is central vein, next is plates of hepatic cells, 3 is sinusoids, 4 is endothelium, 5 is portal vein, 6 is hepatic artery. Figure 14.4, liver lobule, sectional view, transverse section, stain hematoxylin eosin, high magnification. 1 is the interlobular septum, 2 is a lymphatic vessel, 3 is hepatic artery, 4 is portal vein, 5 is bile duct, 6 is interlobular septum, 7 is plates of hepatic cells, 8 is blood cells and sinusoids, 9 is central vein, 10 is endothelial cells and sinusoids. Figure 14.5, bile canaliculi in liver lobule, osmic acid preparation, stain hematoxylin eosin, high magnification. 1 is endothelial cells, 2 is central vein, 3 is the bile canaliculi, 4 is hepatic plates, 5 is bile canaliculi again, 6 is sinusoid.
This is the portal triad, and this is the hepatic artery, and this is the biliary epithelium, and this is the portal vein. Number 1. What is this? Hepatocyte. Number 2. What do you see here, ma? So these red structures are number 3. This space is number 4. 1 is hepatocyte. 2 is, remember the space of disease. So number 3 is endothelial cell. So number 4 is sinusoids. These are all the 4 structures you have to remember. Hepatocytes, space of disease, endothelial cell, basement membrane, first basement membrane, and then above it is the endothelial cell. So we will put 3A and 3B. 3A will be the basement membrane and 3B will be the endothelial cell. And 4 is the sinusoids. We will just draw 4 hepatocytes. And then you have the space of disease and then the basement membrane. And above the basement membrane is the endothelial cell. And after the endothelial cell is the sinusoids. And if you come to this side, again, there's the basement membrane. And you see the endothelial cells here. And you have the space of disease and then the hepatocytes. Hepatocyte, space of disease. And this is the basement membrane, endothelial cell, and sinusoidal space, sinusoids. Who occupies the space of disease? We heard of cells of Ito or stellate cells because they will be star-shaped cells and they are responsible for vitamin A metabolism, and more importantly, there are no fibroblasts in the hepatocytes. These stellate cells are cells of Ito. They produce the fibrous collagenous tissue. They are responsible for cirrhosis development. Another thing is when you see the amyloidosis in the liver, they happens in the space of disease. In the sinusoids, you have the Kupffer cells. And what are the Kupffer cells, ma?
Macrophages.
And few RBCs will be there in the sinusoids. Where is the biliary epithelium and where is the bile coming, ma? Here you have to remember in these lateral margins we have to make some modifications. So these are all the biliary canaliculi. Remember the hepatocytes are producing bile. When you see this, diseases of liver are divided into now disease of hepatocytes, disease of biliary system, diseases in the space of disease, diseases in the sinusoids. For example, chronic venous congestion, this is massive RBC accumulation in the sinusoids. In amyloidosis, it is space of disease. All of you, please try to practice drawing these things.
Super cells in the liver lobule, India ink preparation. First, interlobular septum, endothelial cells, super cells, bile duct, sinusoids, hepatic plates, and portal cells.
Yeah.
Then glycogen granules in the liver cells, then fast stain with a blue counter stain of the nuclei, oil emulsion, sir. Hepatocytes, glycogen granules, sinusoid, glycogen granules, and endothelial cells. Reticular fibers in the sinusoids of the liver lobule, stain reticulin method, medium magnification. Collagen fibers in the interlobular septum, portal vein, bile duct, villi of hepatocyte, hepatic plates, reticular fiber in the wall of the central vein, and reticular fiber in the wall of the sinusoid.
In the reticulin stain, you see how there is only one plate of hepatocytes. Okay, the hepatocytes are normally one, maximum two. When you see more than like a biliary epithelium like this, and when you see, let us take hepatocytes, when you see more hepatocytes, then that is disease, pathology. It can be hyperplasia, it can be adenoma, it can be a hepatocellular carcinoma. Normal is 1 to 2 cell thick. When it is more than 2 cell thick, that is abnormal.
Figure 14.9, wall of gallbladder, stain HNE, low magnification, simple columnar epithelium, lamina propria, diverticular or crypts, elastic fibers, nerves, connective tissue, mucosal folds, diverticular or crypts, venule and arteriole, smooth muscle fibers, artery and vein, and serosa.
What layer is missing in the gallbladder?
Submucosa, sir.
Super. What are all the other structures that doesn't have submucosa?
Ureter, urethra, tongue, and fallopian tube, sir.
And remember the salivary gland, we saw the pancreas, isn't it? So they are arranged in functional unit, in lobular functional units. These are all the one lobule, and this is the other lobule. Okay, and you see the acini, which are nothing but like a parotid gland, serous acini, and they will have the ducts. These are all the ducts, and only the difference is islet cells. These islet cells are very specific for the pancreas. Remember, I told you adrenal gland and pancreas are 2 in 1. So that's the pancreas.
Figure 14.11, pancreatic islet, stain HNE, high magnification. Intercalated duct, cells of pancreatic islet, capillary, connective tissue capsule, and centroacina cells in serous acini. Figure 14.12, pancreatic islet, special preparation, stain gomoris, chrome, alum, hematoxylin, and floxin, high magnification. Alpha cells, capillary and beta cells, connective tissue capsule, then centroacina cells, and serous acini.
Probably if you do IHC, you may see glucagon, alpha cells, insulin, beta cells. Okay, on HNE you cannot see it. And what about these islet cells, ma? How do they secrete their material into the blood? Meryl?
So they secrete directly, sir, through the blood vessels present there, sir.
These are all the organs where the blood vessels acts like ducts. That's why all endocrine organs are highly vascular.